Good to be here, everybody. Thanks for tuning in. Look, massive hemorrhage protocol or massive transfusion protocol. What's the deal? Probably one of the more misunderstood resuscitation applications that we know about. Why? Because for many years, the definition has been imprecise. Its utility called into question, particularly in patients who are bleeding and bleeding acutely. And to be honest, a lot of the terminology, the phraseology, the language that we use around massive hemorrhage protocols is messed up, inaccurate, probably outdated. And it's time for a refresh. I'm an emergency medicine doctor. I'm also a trauma doctor. I spend a lot of time in the trauma room resuscitating trauma patients. And I've seen time and time again a misunderstanding or a misapplication of the concepts related to a massive hemorrhage protocol lead to potentially adverse outcomes for patients. And I think it's time we address that. The thought and the language and the understanding around how to use blood and blood products in trauma patients and all of the related adjuncts that go along with that is changing. It's changed a lot in the past 10 to 15 years. And this discussion is going to help us get caught up on what some of those key changes are. It's probably worth just recalling for the record why we give patients blood and blood products in the first place, particularly in a trauma patient who you think is bleeding. Bear in mind that trauma patients who are bleeding in about 25% of the cases are not just bleeding, but bleeding abnormally or in excess of what you'd expect for a bleeding trauma patient without a coagulopathy, the so-called acute coagulopathy of trauma and shock. And so when we activate something like a massive hemorrhage protocol, when we start giving blood products, and all of the accoutrements that go along with that, we are not trying to restore their normal physiology. And I think that's point number one. That is a post-operative, post-hemorrhage control intervention. In the acutely bleeding patient who you're just trying to keep alive, your goals are different. You're trying to support their ability to clot. And that gets dropped a lot from contemporary thinking around massive hemorrhage protocols. Because when we talk about massive hemorrhage or massive transfusion, we think about just giving blood to restore circulation. That's really not the goal. We're trying to support clotting in a patient who is not only bleeding, but in many cases bleeding abnormally, bleeding in excess of what you'd expect. You're trying to maintain adequate perfusion. That's a compromise, very clearly a compromise and a trade-off. You're not trying to restore that patient's normal perfusing blood pressure, the blood pressure they had before they got shot or got in a car accident, but you're trying to maintain adequate perfusion to the heart and the brain specifically. That doesn't look like normal physiology. It doesn't look like normal vital signs, and it shouldn't. And in fact, if you shoot for that, you're probably going to cause harm rather than help your patient out. And finally, what doesn't get discussed often enough is to maintain things like normal calcemia, or at the very least prevent hypocalcemia, which is a key element of blood and blood clotting, cardiac contractility, and all sorts of other good things to keep your patient alive, as well as preventing things like hyperkalemia. Those things don't get a lot of lip service, and in massive hemorrhage protocol thinking, they get a little bit more attention, which I think is a good thing. Now, this is a man who looks like he's probably going to try and sell you some cryptocurrency, but he's not. This is my friend and collaborator, Andrew Petrosoniak. We've worked and written a lot together on trauma and trauma resuscitation. I show his picture here because Andrew, along with a few other people in our shop in Toronto, are involved in the development of regional guidelines for massive hemorrhage protocols. I'll explain why I'm saying hemorrhage and not transfusion in a second. But if you look north, if you're situated in America, you're going to see Ontario, which is this massive stretch of land that smells like maple syrup and free healthcare. It's not free. We get taxed out the backside for it. But coordinating trauma care across this vast expanse of geography can be challenging, especially when you're moving a critically ill trauma patient from one place to the another. You know, how you resuscitate them and how you organize something complex like a massive hemorrhage protocol around a critically injured patient can be a challenge, a real challenge, especially when different institutions have different guidelines. So Andrew and other people like him sit on these province-wide committees that try to develop regional approaches to massive hemorrhage and massive transfusion. And I think that's a really important concept to put forward for those of you out there that are involved in emergency medicine services, in regional trauma services. The idea of standardizing and organizing your approach to an MHP across multiple jurisdictions can have real benefits and real gains for your patients, as we're seeing here in Ontario. Thanks a lot to the work of Andrew and others. So in an effort to try and sort of distill this down, Andrew and I and an excellent resident here in Toronto named Winnie sat down and wrote out what we think is a bit more of a contemporary approach to massive hemorrhage protocols. It's a short read. It's about 3 pages long. It was published about a year or two ago now, and outlines some of the key concepts that we think are important to remember in a bleeding trauma patient that you're trying to resuscitate. So first, you've heard me say it a bunch of times, massive hemorrhage protocol, not massive transfusion protocol. Why is that? Well, MTP, or massive transfusion, has all of this baggage related to transfusion, the implication that it's simply a matter of giving red blood cells. But as we know, there's so much more to resuscitating a bleeding trauma patient than just giving blood. The idea of an MTP is also attached to the baggage of its former definition, which is, replacing the patient's blood volume in 24 hours or predicted 10 units in 24 hours, which really doesn't apply. Those definitions are completely useless when you're talking about how you should respond to an acutely bleeding trauma patient. And the notion of a massive hemorrhage protocol really is paying some lip service to the notion that you're not just giving blood and blood products, but you're doing things like maintaining normothermia. You're giving adjuncts to help counter coagulopathy. You're trying to maintain things like serum calcium levels. So there's a lot more that goes into a massive hemorrhage protocol conceptually than simply just the notion of giving blood and blood products. And in part, that's what the change in terminology is meant to reflect. One of the first challenges that can come with an MHP is understanding when it's needed. And there are all sorts of ways to try and predict this. When you have a trauma patient who's been shot in the chest and has a systolic pressure of 60, I don't think many people are going to miss the notion that they need blood. But it's the subtle patients, the elderly patients with kind of old person physiology on medications, the very young patients who are going to have young person physiology and are going to maintain their blood pressure until the very end, and may just present with a little bit of tachycardia or blood pressure vital signs that don't look super out of whack. Those patients will fool you. And there is good data to suggest that for every minute of delay for those patients in particular, that you delay getting blood to the bedside, that's associated with a 5% increase in mortality. So there is some rationale and some reason for your patient in particular for being accurate with when you call for blood and blood products. There is clinical judgment. There are scoring scales like the Rapid Assessment of Bleeding and Trauma Patient, the ABC score. None of them are really felt to be particularly superior to one another. None of them are particularly accurate or precise. And to circumvent this, we used to call an MHP essentially on every patient who we thought might need blood, but we found we were wasting a bunch of blood and blood products when we did that. So the concept to introduce you to here is this notion of a critical administration threshold, and it reflects how we approach bleeding trauma patients these days in our trauma room. What the CIT really refers to is the notion that for many of our bleeding trauma patients or patients we think are bleeding or might be in shock, we'll order a couple of units of blood. Initially, we'll have them in the room with us, what might encompass, say, the first pack of an MHP protocol, but not the whole MHP per se. And as we move through resuscitation, if we start to transfuse blood and blood products, we will notice around 2 or 3 units, specifically around 3 units, that we're starting to reach a threshold. Usually beyond 3 units of packed red blood cells, you are past what we identify as the critical administration threshold. Past 3 units of blood typically means that patient's going to need a whole lot more blood and a whole lot more blood products. And it instigates things like matching ratios and considering giving calcium and a bunch of other related adjuncts that are really important. So typically then from a cognitive prompt point of view, and in an effort not to waste blood and blood products, we will start with a few units of blood in our trauma bay. We'll start administering to the patient as we feel we need it. And once we pass that critical administration threshold, which sometimes we do very, very quickly, then we start to activate and turn on our MHP, which is, again, this system-wide response to massive hemorrhage that brings to bear all sorts of resources, from porters to lab technologist resources to hematologists to, obviously, the delivery of blood and blood products to the trauma room. Just going off topic for half a second, I think another interesting signal to pay attention to when you're thinking about activating an MHP is this notion of pulse pressure. Strictly speaking, a blood pressure of 92/78 is not, by ATLS standards anyway, noticeably hypotensive. But the pulse pressure, which is the difference between the two numbers, is actually pretty narrow, certainly less than 30, which in many studies has been identified for hypovolemia as being a narrow pulse pressure. Well, if you see this is actually predictive of a lot of things, and this has been looked at in a few different studies, specifically one where the association between a narrow pulse pressure and the need for a trauma intervention, like giving blood or blood products, the incidence of resuscitative thoracotomy, the need for some sort of emergent surgical intervention, was compared to both normotensive trauma patients and hypotensive trauma patients. So these are patients that have a normal blood pressure, strictly speaking, technically speaking, but they have a narrow pulse pressure. If you compare these patients to patients who don't have either of these things, the incidence of the need for some sort of resuscitative intervention is much, much higher. So simply identifying a narrow pulse pressure alone might, depending on what trauma system you work in and where you work in, be an important prompt for considering turning on an MHP, or at least having blood and blood products at the bedside. None of these things, the critical administration threshold, a narrow pulse pressure, a positive rabbit score, none of them in and of themselves should necessarily be the only predictor. And again, at the bedside with a critically ill patient, you're going to use your best judgment to make the best decision you can. But all of them, if present, should raise your antenna to say, this patient has got a narrow pulse pressure, we've given 2 or 3 units of blood. We're kind of getting along a path where we should really have a cognitive prompt now to consider ordering more blood, and depending on what your institution and organization has put together, turn on an MHP as well. Now, if you have an MHP at your site, and most major sites, even peripheral sites these days, would have something that spells out what an MHP process looks like. Typically, the organization and the delivery of blood and blood products is in packs. And it's important to know what's in your packs, because it's important to know when you ask for MHP Pack 1 and MHP Pack 2, what you're going to get. As outlined, for our MHP, typically the first unit is just blood. And we may start with that. And once we cross that critical administration threshold of 3-ish units of blood, that prompts us to activate and request the rest. And as you can see, once you get down to cooler 2, you're starting to talk about packs that match ratios of blood products. Most evidence these days would suggest that you don't necessarily have to be at a 1-to-1 ratio of red cells to FFP. We use a ratio that looks a little bit more like 1.5 to 1, and that's what this pack reflects. Every institution is going to develop things that look a little bit different, but it's important to know what your institution has put together and what your packs involve. And as you can see, you get 4 units of red cells. If you work in an organization or in an environment where you don't necessarily have access to things like plasma or cryoprecipitate, then those packs may include things like 2,000 units of prothrombin complex, 4 grams of fibrinogen, which may stand in as a substitute, as a bridge for systems where you're moving a patient from a lower resource environment that doesn't have access to those products to a higher resource environment like a trauma center. So that's what you're seeing in parentheses there. And then down to cooler 3, where you may have included additional plasma, but if you don't, again, things like prothrombin complex and fibrinogen concentrate may be considered bridges or adjuncts. What you don't see on there, and I think conspicuous in its absence, is platelets. And we used to speak very much about a 1-to-1-to-1 ratio of blood products, or 1.5 to 1-to-1, and one of those ones implicitly was transfusing platelets. The data on this has always been fuzzy. Nobody's ever really known what to do with platelets and where to include them and what the benefit was. And as it turns out, the benefit is probably not great as an empiric use of platelet transfusion as part of your MHP. The recommendation these days is to simply include platelets in your resuscitation if you have a platelet count of less than 50,000 or less than 100,000 in the case of intracranial bleeding. Platelets are a dirty blood product. They're a high association compared to others with things like bacterial contamination and sepsis. And their overall benefit is relatively poorly understood and poorly delineated. So rather than use a ratio-based approach with platelets, we simply base the use of platelets on lab parameters and the clinical picture, whether or not there is intracranial bleeding or not. There are, of course, lots of adjuncts to consider. One of the first things you may notice if you looked at our regional MHP protocols is that tranexamic acid is given as a 2-gram bolus. The data on this reflects the fact that 2 grams, as opposed to a gram and a gram, as you might be familiar with some of the past protocols, and certainly from the original study protocols on TXA, is as safe, as efficacious, as efficient. And in many of those studies, if you look at real-world application of a gram plus a gram, the second gram as an infusion of TXA often gets forgotten about. So the patient's only getting 1 gram instead of 2, which is less beneficial. We also know that there's a huge dose-response curve with TXA, and the earlier you get it in, predicated on time, the more benefit there is. So if you can get tranexamic acid 2 grams in early as opposed to a gram and then a gram later, or just forgetting about that second gram completely, you're going to benefit your patient much, much more. Fibrinogen concentrate, lots has been written about this recently, whether you're getting your fibrinogen from fibrinogen concentrate or cryoprecipitate. The bottom line is it's really meant to be used in a patient who is measurably and demonstrably hypofibrinogenemic. And that means your lab parameters are reflecting a low fibrinogen, or if you're using TEG or ROTEM, that is showing hyperfibrinolysis or low fibrinogen concentrate. And if that's the case, then you're responding with one of 2 adjuncts. If your fibrinogen is normal, essentially there still is fibrinogen contained in your FFP and you're replacing it by that mechanism. But if it's measurably low or your TEG or ROTEM parameters are off, then you can respond with things like cryo or for us and for many trauma centers these days, it's fibrinogen concentrate. Even outside of a trauma center, fibrinogen concentrate just tends to be a lot easier to draw up, a lot easier to administer, and is being used more and more commonly. And I think calcium deserves some special mention here because calcium is kind of the forgotten element of massive hemorrhage protocols. And I think it's perhaps worth touching on for a second. It's worth remembering that calcium is an important part of things like platelet function. Platelets, along with fibrinogen, are your 2 earliest components of clot formation. So if you don't have good platelet function, you're not going to form much of a clot. It is a key element of many factors in the clotting cascade, many of which I have long since forgotten, but I'll just pretend to know them so I can mention them here. And as mentioned, for your heart, you kind of need calcium for your heart to contract. And we see this in non-trauma related medical cases like sepsis, where if somebody goes hypocalcemic, they become sort of pressor resistant in terms of hypotension. Sometimes you give those patients a little bit of calcium and they often bounce right back. That's true in trauma as well. And a low calcium is incredibly prevalent. About 97% of massively bleeding patients are going to experience some degree of hypocalcemia, broadly speaking defined as a measured calcium less than 1. And the associations here are broad and impactful, including increased incidence of death, increased transfusion requirements, and more significant and more severe coagulopathies. So it's very common and it's very impactful in terms of its association with bad things in trauma. Enough so that many people would talk about reorganizing or renaming the sort of triangle of death of acidosis and coagulopathy and hypothermia as something with 4 sides, like, say, the lethal rhomboid, if you want to go down that direction, because I think rhomboids sound really, really horrifying. And that 4th corner of the rhomboid is calcium. You can think about calcium in your 1-to-1-to-1 trauma resuscitation as being that one that platelets isn't anymore. And as you're giving blood and blood products, you're also giving calcium early and often to stave off the generation of hypocalcemia. It's easy to say that, of course, but logistics beat strategy every time. So how do you logistically make it happen that you don't forget calcium as part of your early MHP response? Well, we'd like to think a little bit about this notion of the MHP Starter Pack, which is if you're getting rolling on a patient who you thinking is bleeding, who you're thinking and predicting using all of your predictive measures is going to need a massive hemorrhage protocol somewhere along the line. As you start to consider, and edge up on that critical administration threshold, the 2-2-2 framework for the MHP Starter Pack is a nice, easy thing to remember, starting with 2 units of packed red blood cells, 2 grams of tranexamic acid at 2 grams of calcium chloride. This is a preemptive approach. That is to say, you're giving calcium early, even before measuring it, even before necessarily understanding if it's dropped or not, because the implication in severely bleeding trauma patients is that it most likely has dropped, and you're trying to stay ahead of hypocalcemia rather than trying to catch up. And this approach used in the military for a long while now has been demonstrated to prevent, in the majority of cases, the occurrence of hypocalcemia in the first place, rather than letting hypocalcemia develop and then trying to catch up. There is the theoretical concern that these patients might get hypercalcemic, and the data is still a little bit out on that. You can titrate how much calcium you give. Initially, if you have an iStat in your trauma room, which we don't, you can just measure calcium, and that's probably an easier way to do this. But if you are in a resource deplete setting, or if you don't have the capacity to measure calcium at the bedside, then the starter pack is a way to prompt you to at least consider the early administration of calcium along with your other MHP adjuncts. And the last thing to bear in mind is your targets. How do you titrate your MHP? What are you shooting for? Well, this remains relatively imprecise. Again, you're not shooting for the normalization of patients' vital signs and blood pressure. My own particular take is you want to maintain adequate peripheral pulses, ideally adequate central pulses in penetrating trauma patients, and nothing more than that. And clinical markers of perfusion like capillary refill, extremities, mentation, that sort of thing. That changes a little bit depending on where you are in your resuscitation. So if your patient is trending downwards, trending upwards in terms of the vital signs, if you're in a peri-intubation period, arguably you may shoot for slightly different targets there. And of course, all of this changes if you do an intervention like Reboa, or you do a resuscitative thoracotomy and cross clamp, or certainly once you get to the operating room and your surgeons are able to surgically reverse or stave bleeding, then all of that changes. So it's perhaps messy to say that there's no perfect answer, but there's no perfect answer. Certainly remember that in a patient who's actively bleeding, in a patient who's got ongoing hemorrhage that can't be controlled, your goal is not to restore normal vital signs. In fact, that's probably counterproductive and is going to make your patient bleed more and become more coagulopathic. Finally, the last thing you need to know with a massive hemorrhage protocol is when to turn it off. And again, no perfect answer here, except to say that any contemporary MHP needs to have some pre-specified targets and good communication between a trauma team, a surgical team, a trauma intensive care team, so that everyone has a similar definition of what the goals are and everyone has a shared understanding of when to switch it off. It's going to vary depending on patient to patient, but if this isn't specified ahead of time, it can be really easy once you get an MHP rolling to just keep giving and keep giving and keep giving blood products, which learns to things like volume overload, transfusion-associated lung injury, worsening coagulopathy, and all of the other bad things that can come along with an MHP that's kind of wheeling out of control. So whatever your guidelines suggest and whatever your institutional protocol suggests, it's important to have pre-specified, well understood, organizationally recognized targets for when to switch an MHP off so you don't end up overdoing it. Again, this framework is contained in our wee little paper. These are the 7 T's. This is how we spelt it out. There's a lot more to say within that. But if you follow this protocol, you're going to have a better understanding of when to start, how to move forward, and ideally when you're going to terminate your MHP. And that is going to help you look after your very sickest trauma patients.